I'm Phil Boudreau. I met some of you last night. Hope to meet some more of you today, and you might be hearing a little bit from me later on this afternoon. Dr. Odorizio and I kind of flipped programs because he has a plane to catch. And Dr. Odorizio should be called the godfather of peptides. Right. I think, based on how he...
Guido Sheik.
Yeah.
That's right, yeah. So we've elevated him now.
Yeah, I'll take it.
Okie dokie, thank you. Okay, the first one I'll think we'll send to, well, we'll just ask the panel what their opinion is. How often should a patient with a midgut carcinoid with lymph node metastases have an Actria scan?
I think for us, the way we do it is you do one to see if the initial one to see if they're receptor positive, and virtually 95% of the midguts are positive. But then after that, I've only done them with intent to treat. So that is for the best we had was the Actria scan, which would bring in the PRRNT. But in the next 3 years, in fact, now most of the centers in Europe aren't even using the Actria scan. So I do it initially to establish that they have receptors, they have uptake, to justify, as Lowell pointed up, to justify the somatostatin key, the sandostatin. But then after that, it's only with intent to treat when you document further progression by CT.
When Mallinckrodt developed the Actria scan, they did it strictly as a one-time event. They've left it to the practitioners to figure out how to follow. So the guidelines are vague on purpose. The weakness on the Actria scan is you don't have size, but the strength is that you image the whole body, so you can pick up places that you wouldn't normally do scans. So what I think a lot of us do is individualize. For some people, we might get an Actria scan maybe once a year or every other year, but not necessarily do it at the same time we get a CT scan, so we can increase our coverage of not getting radiation with the CT as often. Some people who are allergic to contrast, we really do not like to get a CT scan or an MRI without contrast, because we really need the multi-phases to understand and see what we're looking at, have greater sensitivity. So we'll do what we call a fusion Actria scan with a CT for the contrast allergic person, and then we can keep up with what's going on.
Just to comment on that, as Lowell points up, you get a spec imaging, which is the Actria scan plus the CT. It's a low resolution CT, but the amount of radiation is 6 times greater with the Actria scan CT than it is with the gallium PET, and it's 2.4 versus 6. 4 times that or 5 times that, but so there is not insignificant risk to the Actria scan CT, and so hopefully that'll be a moot point when the gallium gets foothold.
Well, yes, no, maybe. You're going to get rid of the Actria scan part, but what Dr. Odo didn't then finish the sentence, which I think is important. Not going to get rid of the CT portion. It's going to be still a fused image between now gallium-68 and a CAT scan. They're going to drop off the Actria scan, put on the gallium-68 scan, but the CT radiation and the CT portion to localize anatomically where that hot spot is will still be there.
It will be, and the CT, though, I think the PET CT has a whole different amount of radiation than the Actria scan CT because of the quality of the CT. So Gene's right. You will need the CT again for anatomy, but it's again the radiation with both toe to toe is different overall.
Okay, these questions I'm going to kind of group together. If a primary tumor is removed, how long is the tissue good for further testing? And then, this is a similar question. Tumor was removed in 2006 in a small city hospital, and a liver biopsy was taken. However, the testing was for Ki-67 was not done. What advice do you have to be able to get Ki-67 testing? Is it worth doing later? And corollary to that is, how do you determine drug sensitivity testing if you're on a chemotherapy?
I'll take those. Ki-67 done on fixed tissue. So you took your tumor, dropped it in formaldehyde, let it pickle, and then slice it and put it on glass. Good forever. Ki-67 can be done from tissue that's probably 20, 30, 40 years old.
As long as it's in the paraffin block.
While it's in the paraffin block or fixed, that they can put it in a paraffin block. Once you throw it away, though, it's gone, and a lot of hospitals throw away your tissue after 10 years. Tumor, how long is your primary tumor good for after it's been taken out? All depends on what you want to do. If you want to do it for Ki-67 and you've pickled it in formaldehyde, like I said, it's good forever. If you're going to do things like drug sensitivity testing or angiogenesis testing in my assay, then it's only good as long as it's fresh, which means that it's still alive. There is a special technique that we do in our lab called cryopreservation. And we know that we have a tumor that was 12 years ago that we cryopreserved, put it in like suspended animation, and kept it in liquid nitrogen for 12 years. Patient had a recurrence. We thawed out the tumor. It's still alive, but in the deep sleep. It's so that is good for at least 12 years, we know. I've never done one longer than 12 years, but a lot of time. But the minute you put it in formaldehyde, the minute you freeze it, freeze it, like an ice cube, it's dead, and certain tests that require living tissue can't be done. But the things that are stains can be done almost forever. Drug sensitivity testing, I'm sorry, I got one last one.
Okay.
Drug sensitivity testing, again, requires living tissue. So it's done today when your tumor comes out, or you cryopreserve the tumor, and you can do it in the future for years and years and years. Yeah. And one of the things we like to do in the lab is when we get tissue straight from the operating room, whether it's these guys at Indiana who send the tissue down on ice, or folks like Phil who sends it over from the operating room at Kenner, we use the fresh tissue immediately, and then we cryopreserve it so we have like a bank of tissue that we can pull up of yours if and when we ever need it, that tissue is still alive.
Yeah. And just a comment, and that was excellent. It's always best to keep it in the paraffin block, because a lot of centers like Mayo will send cut slides for staining. But when you cut the slide, when you make the slide from the tissue, it's a very thin section, and the clock does run to when you can get good staining with them. So when they send a series of unstained slides to be stained, that clock runs. So it's always good to try, if they request your tumor, to make sure the block is sent, because it's as Gene says, it's almost immortal when it's in a block form. But once you make a slide from it, the clock runs to about 3 years or 4 years to get good staining on the Ki-67.
So basically what you would do is you would request the pathologist that has the specimen to send the tissue blocks
Yes.
to one of the centers, that just request them to send it for Ki-67 staining, and they usually will know where to send it. If not, you can have them call one of the referring centers for some information of who around the country can do the staining for them. But they should still have an original specimen in a paraffin, mounted in a chunk of wax, basically.
And if the time is coming, like you're 8 or 9 years out from your surgery, and you don't want them to throw away your block, have them give you the block. You know, it's like I tell my wife, keep your mammograms underneath your bed. Nobody gives a damn about your mammogram as much as you do.
Okay, this is a quick one for Dr. Otto. Is it true that the tumor is it the tumor It's the tumor that you don't see that kills you. And if the tumor doesn't have receptors and you give PRRT, is it like pouring a bucket of water on a forest fire?
So that's, it's a two-part question. It's a good one. I think there's probably two population of cells, even with and that's where the Octria scan is a little deceptive, just like I-131s for thyroid cancer. It looks black, as you saw, all the way through. And there's a population probably of the ones without the receptors. The good news is if you get PRRT, remember it kills in all directions, 8 millimeters. So you do kill a lot of the receptor, non-receptor tumor cells. What we're finding, we've sent about 400 folks over to Basel for PRNT, is that there is a percent, like I said, 20% progress. And what happens after the second treatment is if you do an FDG PET, one that measures activity, you'll now see the FDG PET start to get higher. And those are the ones, as you allude to, that are going to be more aggressive. And I think the answer is you treat those aggressively, but you don't wait a year or two to test it. So we do a they do a gallium-68 after the treatment, before and after the treatment, and they have an idea of the uptake, and they do an FDG PET at my request after the second treatment so that we know if there's a population of rapidly growing cells that you can jump on. And we've been successful with a more aggressive chemo-type therapy as when they don't have the receptors. So the answer, I think there are two populations. You can kill them with crossfire from the uptake cell. It'll hit it. Bystander.
Innocent bystander.
Innocent bystander get killed, but it doesn't do it all the time, because if the population that's bad is in there, it comes out as you kill the easy cells.
And like I said, and I showed you, some of those tumors, like the lymph nodes,
Yeah.
if you have 20 lymph nodes, you may have lymph nodes that just don't have the receptor on any of the tissue, and yet still have the cancer. And those are the ones that are going to come back and bite you on the butt. So just scanning with gallium or just scanning with Octria scan doesn't tell the story, because what if you have a lymph node that doesn't have somatostatin receptors? It's going to pick up on any of the scan that depend on somatostatin. So that's why we'll do MIBG scans,
Yes.
We'll do CAT scans, we'll do MRI scans, we'll do ultrasounds, looking at all the different ways you can try to find those guys who are trying to escape and bite you on the butt.
And that makes an argument for more peptide analogs, the the peptide that will see more than one receptor. As Gene alludes to, are peptides, and they have them now. The GLP-1 now is labeled, and it will eventually be probably used for therapy for malignant insulinomas, because it has such a high affinity for gastrin, VIP. The other peptides we alluded to will probably be targeting agents for maybe non-neuroendocrine tumors.
Yeah, that's a very good point. There's a guy named Saul Rivkin who's out in the Seattle area, and Dr. Rivkin, he's an ovarian cancer expert, and he's found that these plain old everyday run-of-the-mill ovarian cancers have what are called bombesin or GRP receptors, so that it may be a way to scan and detect people with ovarian cancer earlier, because that's a hard cancer to find.
This is along those lines. I think you've already answered it. Will gallium-68 pick up only neuroendocrine tumors, or will it identify other tumor types at the same time?
So it's highly, highly specific for the receptor we heard about. Remember, somatostatin has 5 receptor subtypes. 1, 2, 3, 4, and 5. Gene alluded to them. Number 2 is the one that seems to be the action Jackson, because it'll take the sandostatin to the receptor and take it inside the cell. So it's the one that goes inside the cell. So it's highly specific for the SST2, to some degree SST5, as Lowell alluded to with that drug called pezariatide. It has 4, but more receptors may not be better. as Gene showed, they may not be there at all. And so I think it's going to broaden out to be other, Gene has an analog that he developed a few years ago, and he and I with another analog. So we'll be testing those with the DOTA. We'll be putting the linker on and the gallium to see if these are good in animal models first, and then hopefully go into humans with it.
The perfect scan will be the thing you walk through in the airport that's going to scan you for everything
Yeah,
and tell you what's wrong with you.
it is. I did just
Go straight to jail, go straight to the operating room.
Let me tell you how good that is. The first time I went in, I took everything out of my pockets. I go in, put my hands on, and the guy says, "Are you sure you took everything out of your pockets?" I said, "Yes." He said, "Check your left pocket." There was a little antacid about the size of a, and I said, "Oh my goodness, what else did you see?" I asked him. I couldn't believe it.
So
It was too small to see.
while we're looking for things,
That's what he said.
moving right along, folks. I knew that was coming. I continue to
set
collect
me
my
up.
urine
I
for
couldn't
24-hour urine for 5-HIA for monitoring my carcinoid liver mets. Why should I keep doing this? I've been collecting urine for more than 6 years. Perhaps talk a bit about monitoring, Lowell.
Good.
We're all looking for a substance that would be real sensitive to pick up early disease. We don't have anything we can use for screening. So people who have very nonspecific symptoms, we really don't have a perfect type of marker. What we see is chromogranin being used, particularly people who may have flushing. Our ideal marker would be something that would be present with minimal amount of disease. As Tom covered in his talk, the pancreastatin, we think, is probably going to be more sensitive to follow things, but it's not caught on well. You have to have special tubes called Z-tubes, and these tubes have to be ordered. They're expensive. They have an expiration date on them based on how they're stored. At room temperature, they're good for a month. When they're refrigerated good for a year. These tubes have to be requested to get the pancreastatin level done. So most labs are not going to have them. You ask your physician for a pancreastatin level, and they're going to say, "What?" So it's going to take some effort to do that. 5-HIA is probably not real sensitive to pick up early disease. It's something that we can use to monitor disease once it's elevated, but it's really not that helpful to pick up early disease. So when we're watching for signs of recurrence, we'll usually get a panel. We'll get the chromogranin A, we'll get the pancreastatin, and we may or may not get 5-HIA based upon where the primary is, and may or may not get serotonin levels. And I think from what Gene covers this morning, we might end up using serotonin more for surveillance purposes because it's helpful maybe to pick up the diagnosis, but blood serotonin levels is not good for following the disease as it's episodically secreted and compartmentalized.
The one thing that I got to remind everybody in this room is that the proton pump inhibitors, those drugs, the purple pills, the Afex, the Nexium, the omeprazole, all those kind of things, increase your chromogranin. So that frightens people, but if you're on your Nexium or whatever, the study that we just finished with Dr. Raines in our group, who's a gastroenterologist, omeprazole and all these things raise your chromogranin, they raise your gastrin level, but they don't affect your pancreastatin. So that may be the way to tell whether it's the drug that's raising your chromogranin or tumor, is to measure also a pancreastatin and a gastrin.
The other component to the question is how often. If we can see disease on a scan, we'll do markers every 3 or 4 months. If we can't see disease on a scan, we might do them once or twice a year.
And the thing about 5-HIA that's probably meaningful to us is when we see markedly elevated, persistently elevated 5-HIA levels, we need to really be on guard for carcinoid-induced heart disease, because it tends to be a kind of an early warning that that person is on their way to having their heart valves destroyed by some of the, probably the same processes that cause all the desmoplastic reaction and the scarring and the fibrosis, and it scars up and fibrosis and really messes up the heart valves. And so 5-HIA, and from that aspect, from people that have elevated levels, need to be watched closer than the ones that obviously that have normal levels.
And I think Mayo early on used the number 350 milligrams for the high-risk right-sided heart disease. It's now come down to, I think, about 250. But if you look at the Mayo data and the valves, one of the things that's happened in the last decade and a half is that they're doing fewer of them. And they now, I think, admit that the introduction of octreotide has dramatically reduced the serotonin release from the tumors in the liver. But again, it's not 100%. It's probably about 50 or 60% reduction, but it's still, it takes you out of that alarm zone. Go ahead.
To follow on to the PPI discussion, how long a holiday do you have to take?
So I was just going to follow up on that. Gene's point's well taken. And remember, I thought I commented, it's the potency of the PPI and the duration of the PPI. There is no answer to that. I think if you're on Prilosec, the minimum inhibitor, you can probably 2 or 3 weeks. But even Dr. Warner said at 1.6 weeks. But we've seen them as far out as 2 months before you can, and all you have to do is follow the gastrin and the chromogranin A. The gastrin will start to drop, and that's the first, because gastrin is what turns on the chromogranin A from the stomach. So you just do a gastrin and you'll be able to, some folks can't come off, and that's the group you have to maybe think about using octreotide.
And that's the other group that, if you do it exactly the same way every time, then, maybe, in other words, take your proton pump inhibitor every day at 8 o'clock in the morning or every night at 8 p.m. And then if you're going to get your markers done, make sure that every time, you smile, you eat a cheese sandwich for lunch. I'm being facetious, but the more things that you can keep the same, if you can't get off the drugs, like you have terrible GERD, terrible Barrett's esophagus, and you just have to be on the drug, then try to make every time you draw your markers exactly as close to one another as you can. That may be the best you can do sometimes.
Questions for Dr. Tector in Transplant? I want to grab him before he gets called away again. Such is the life of a transplant surgeon. You never know when your phone's going to ring and you have to go jump up and do a donor. I remember those days so well. So I'm going to kind of group these together. Will transplants be approved for neuroendocrine tumors in carcinoid patients since there's such a scarcity of organs? And basically, corollary to that question, how difficult is it to get all the organs at the same time ready for a multi-organ transplant?
I'll answer the first one. I'll answer the second question first. You get the organs from the same donor. And so if you think about it, when you do a transplant, there is no indication for solitary stomach transplant. So that organ is widely available. There are about 6,000 to 8,000 donors a year in the United States. There are about 1,200 to 2,000 pancreas transplants. So there are a lot of pancreases that are still available. Isolated bowel transplants, counting multivisceral transplants, there's about 200 to 220 bowel transplants done a year in the United States. So there are donors above and beyond. The question becomes, is the liver available? And the liver allocation goes such that they allocate the livers to people that are going to die within a week. They're called status 1 patients, and then a lot of times they can allocate the liver off of the intestine list. Because they're looking at the intestine as a special, needing the liver with the intestine as a special need, and it's a smaller number of patients. So right now, that's how the allocation goes. So it's actually not that difficult. Right now, patients typically wait about a month on the wait list.
Listen carefully. A month. I mean, if people are on liver transplant lists for a year or two. So, I mean, a month is incredible.
Now, at our center, the wait time for a liver transplant is about 6 weeks. And some of that has to do with the fact that, quite frankly, we go out and look at just about every liver offer there is. So we're going to California, we're going to New York, we're going to, we go to Canada sometimes, we've been to Mexico. we go to Puerto Rico. So I mean, we look at all, even if they sound bad, until you actually go look and see it yourself, it's hard to tell.
Yeah.
So that's one issue. As far as whether or not you can get neuroendocrine tumors approved for transplant, we are getting the patients approved, so their insurance is paying for it.
Wow.
It is not a straight shot.
Yeah.
Like I told you, we hired a lobbyist. God, he's mean. I'm glad he's yelling at them and not me. But it's been very effective. So we are usually able to get it through. Sometimes there are delays in it, and it can be exasperating. But if you
But
stick
of
to
the
it, you can get
5
it.
people that we've sent up to them, that has not been the rate limiting step. I mean, we had one lady who decided to go to Pittsburgh because she wanted something else done. That didn't have a good outcome, but the 2 people have been transplanted, you know, and again, no problems with insurance. And the other 2 people who are waiting have had no problem with their insurance. So that doesn't seem, unlike everything else you guys are battling with octreotide, et cetera, that battle seems like they're winning.
Yeah, and just a comment that was brought up, if I may, and this is dangerous territory, but I'd like to see if it's true. In our experience, the thing that folks who have the involvement with neuroendocrine tumors should know or need to know is that, you know, with a liver transplant, they have a score, a MELD score, and that's why it's so difficult a lot of times for neuroendocrine tumors to be on a liver transplant list. With underlying liver disease, it's a downhill course all the time until the score is reached and they're eligible. In neuroendocrine tumors, it takes a huge burden before your liver function starts to deteriorate. Our experience is up to 75% liver tumor burden, and the function will remain very good. So the good news of this is that, you know, the job becomes for all of us to exercise options to save the liver. And all the options that we alluded to or that you are all aware of are really most important to save the liver. Now, the ones where have a lot of extrahepatic disease, that this is really a remarkable thing in terms of...
And makes it easier to get a liver.
And yeah, that's exactly what we're hearing today, because you have the ones that have 30% liver involvement, but then a lot of abdominal involvement. So that's a very good point. So, but in general, the liver, is that not true? I mean, I think the liver does very well for a long time with
That is
neuroendocrine
absolutely
tumors.
true. The one other thing I would say is, so in my talk, I was saying sometimes I never understood all the really smart doctors, because they would make up their mind without getting out of bed and going and looking at these organs. And so a lot of these organs that we get, so like for us to get a liver out of California or New York, everybody in those areas had to turn it down. And they turn it down without looking at it. And so, I mean, it's hard to do, okay, to be up at night, and then it's not like being a third shift worker, because then you still have to go to clinic and they're mad at you when you're late and they, you know, don't think you smiled enough. But you have to, so, you know, going and looking at all these organs also makes it very possible for us to do this. But if you look, the rate of primary non-function, so that means you put the organs in and they didn't work, is 0. So we are going out and looking at good organs. It's not, because people say, oh, are you going to put junk in me or any old, then that is absolutely not the case. But so you just got to go look.
Yeah, amazing.
I have a question on that.
Sure.
How do you match?
Blood group.
Blood group only.
Blood group and some association with size sometimes is an issue.
Smaller people wait longer. I mean, clearly there are a lot of, I'm like normal size in Indiana, so, and my wife says I'm fat. So clearly smaller people do have to wait longer. Sometimes they get lucky and get something right away, but there just aren't as many small people.
There were several questions on liver transplant candidacy about what makes a good candidate, what makes a poor candidate. I would just like to add a little corollary to that, whether Ki-67 and degree of differentiation factors into your decision.
So I'll answer that one right away. To start with, no, we have not factored that in. We may start. Clearly, right now, I believe we are the only center doing the multivisceral transplants for the neuroendocrine tumors. And so if you look in the United States this year, right now it's on a national database, so you can follow it. There have been 24 multivisceral transplants in America this year. We've done 23 of those. So there's whenever you're that alone, you have to be very careful about your, what's going on and how things are going. But so,
And it makes sense to probably, if you're thinking about this, go to a carcinoid expert first, get them to evaluate whether you're a candidate, because these guys are very good at what they do. But like Joe will tell you, they're not neuroendocrine experts. They are transplant experts. But somebody like Dr. Odo evaluate your disease, and if he says, hey, I think you're an ideal candidate to go to Joe, then you've got the marriage made in heaven. You got your neuroendocrine expert who can help follow your disease, and these guys who can do and follow your transplant. And it don't get no better than that.
Yeah, and it kind of in follow-up to the KI-67 question, it's a good one, but you can now think about theranostics and how that could help prepare for perhaps
Or rule you out.
or rule you out.
Yeah,
I mean,
you're not
and,
a good candidate.
and to have quantifiable gallium-68 after therapy, and you go to the transplanters and said, look, these lesions were here before, and there's no uptake now, or they're at neutral, go ahead and do your thing. That starts to work and tie both together. And I think that's where it's going to end up being.
One thing, though, that you got to know is that Joe and the group have actually been willing to do people who have limited disease outside of the abdomen, that will say, would you guys do it if we can get rid of these lymph nodes in the chest, or a lymph node up in the shoulder blade, or in the under the collarbone? And they'll look at it and say, yeah, if you can get rid of this and this, then we'll do our part. And so again, working as a team makes a big difference.
And I think I think the earlier information was, folks with midgut tumors that went beyond the liver. It used to be 10% went to the liver, and then about 10% beyond the liver into bone or into lung. And I think we're seeing more of this over time, of these going to other areas. So I think the whole advent of targeted radionuclide therapy is with proper receptor identification is going to it'll be okay. We can fix that.
Just as an aside, as part of one's evaluation, and that it's always on our radar screen when we evaluate patients, since I sort of wear both hats as a transplanter and a neuroendocrine tumor surgeon, that is the final pathway going to be a transplant somewhere down the road, and are any of the things we're going to do along the way going to mitigate against that transplant and make it not possible to be done? That's always in the back of our mind, is sequencing of the different therapies and different treatments.
Yes.
Because sometimes if you make the wrong call and do the wrong thing first, now you've knocked a person out of the box for the next half a dozen things you've intended to do. So I think it's important to go to a place that kind of can give you the big picture of what the different options might be, and it really is an individualized therapy. I have one last question we'll have for Dr. Anthony about sunitinib and Afinitor are approved for pancreatic neuroendocrine tumors. Are there situations where they are appropriate for carcinoids and other non-pancreatic neuroendocrine tumors?
The long and short of it would be in the context of a clinical trial, or if a pharmacy benefits coverage, insurance coverage would pay for it off-label. The RAD-001 everolimus or Afinitor that trial was done, called Radiant 2. It only showed 22% risk of decreased progression, so 1 out of 5 people you may say benefit in delaying it. And the regulatory authority, it's not been before the FDA yet, but the perspective is, the perception, which ends up being translated into reality, is that a 22% benefit based on the fact that it's long chronic therapy, that the potential side effects, and the side effect that was emphasized was tiredness, that it wasn't, quote, good enough. The side effects are the same whether that was shown in the Radiant 3 trial, what I showed you. This exactly the same side effects. So I've used it. in those other situations. I see it works, and I fight. I'm a champion to try to get it approved, but it is an uphill battle.
And the cost is not insignificant.
That's why.
Yeah, I mean, when Dr. Anthony talks about off-label and no approval, it's up to, both meds, I think, are between $450, $500 a day a pill,
$500 a day?
a pill. Yeah, so it's, yeah.
But it varies, it really varies from person to person. So what we frequently will do is prescribe it and then see what the hurdles are.
Yeah, you throw it out.
You throw it out there, because if you don't throw it out there, you don't know what the answer is. So you just try. Some insurance carriers may be a little more liberal than others. Sometimes we can object to it and appeal it and talk to somebody above the first level of denial. And occasionally that works. It's just really variable from company to company and how strict they are.
You know, it's interesting, remember that when you have a transplant, you get put on drugs that are immunosuppressants. Remember, Afinitor is one of those drugs, was developed originally as an immunosuppressant to be used in transplant. So they're used at different doses, but it's the same drug used for immunosuppressing a liver transplant as somebody who's put on RAD-001 or Afinitor.
Just one follow-up to Lowell's point, and that is you try it. You put it out there to see what insurances will do. The same obtains for right now when we have to seek PRNT in Europe, and because it's not here approved by the FDA. But our nurse manager here is here today, Jan Weatherford, and she's done an enormous amount of compiling information from the value of PRNT with a letter to insurances and petition, and we're about 6.5 out of 10 of getting coverage for folks that go over. And so it's really worth going and trying to, you have to go over, you have to pay, you have to get a receipt, you come back, and then that's when we go after the insurances to get coverage. So that should not be, as Lowell alludes to, that should not be a reason for you to be more stressed for you, that it can be covered, because they consider it standard level of care in Europe, and we just don't have the term here yet.
Thank you, everybody.